This presentation is an evidence-based update, largely centered around the NICE and J18 guidelines, but specifically tailored to our local context here in Hong Kong. Slide 2. Paper header. To understand why this update is necessary, we must look at our local data. I want to draw your attention to the study published in the Journal of Pediatric Endocrinology and Metabolism in 2022 by Dr. Fur, Sarah Poon, and her colleagues. This was an 11-year review conducted right here in Hong Kong, looking at children with new onset type 1 diabetes. Slide 3. Epidemiology. Hong Kong. So, why is this topic vital for us? If you look at the graph on the left, you will see the prevalence of DTA at diagnosis. In Hong Kong, 43.3% of children with new onset type 1 diabetes present with DTA ADA. When you compare this to the USA at roughly 28% or Sweden at roughly 19%, our rate is nearly double that of Western countries. The study identified key risk factors for our population. Specifically, children under 3 years old are at the highest risk. Furthermore, these patients often present with a shorter duration of symptoms, suggesting rapid decompensation. Younger children simply have more aggressive disease because the process of beta cell destruction happens much faster. Slide 4-5. Local practice. And Dr. Poon's study also audited our management practices in the AED, and it revealed some significant variations that we need to address. The concerning finding was that 12.4% of children still received insulin boluses at the ED. As we will discuss later, this is contraindicated due to the risk of cerebral edema. Furthermore, only 58.9% received the appropriate normal saline fluid bolus. Currently, our cerebral edema rate stands at 0.8%. While that sounds low, it is a life-threatening complication, and standardized care is our best defense against it. Slide 6. NICE guideline cover. Therefore, to standardize our care and improve safety, we are aligning our protocol with the NICE and J18 guideline. Diabetes, type 1 and type 2, in children and young people, diagnosis and management. Slide 7. Diagnostic criteria. Let's start with the basics. Diagnosis. DTA is defined by a triad. First, hyperglycemia. Plasma glucose greater than 11 LOL. Second, acidosis. pH less than 7.3 or bicarbonate less than 15 mmol. Third, ketosis. Ketonemia greater than 3 mol or ketonuria of 2 or more. I want to share a clinical pearl here. Be very careful of euglycemic DTA. This can occur in children who are already on insulin therapy. Their blood sugar might look normal, but they are in DTA. So, if a child is symptomatic, always check a gas and ketone level, even if the glucose appears normal. Slide 8. Severity classification. Once you have confirmed the diagnosis, you must immediately grade the severity. This isn't just for documentation. It dictates our fluid mathematics. Mild DKA is a pH below 732. Moderate DKA is a pH below 7. For both mild and moderate cases, we assume 5% dehydration. Severe DKA is a pH below 7.1 or bicarbonate below 5 to 1. For these patients, we assume 10% dehydration. Please note, any case of severe DKA warrants admission to the ICU. Slide 9. Diagnostic pitfalls before we move to treatment. Let's briefly touch on 3 common diagnostic pitfalls where we often get tripped up. First, respiratory dottery. The deep, rapid small breathing of acidosis is often mistaken for asthma or pneumonia. Action. Check a glucose before you start nebulizers. Second, abdominal. Acidosis causes severe abdominal pain that mimics appendicitis. We call it the acute abdomen of DTA. Action. Rule out DTA before referring to the surgeons. Third, infection. You will often see a high white cell count. This is a stress response in DTAA and doesn't always mean sepsis. Action. Look for other clinical signs of infection rather than relying solely on the white cell count. Slide 10. Initial assessment checklist. Here is your checklist for the first hour. Immediate. You need capillary glucose and ketones, preferably BOHA-B, and a venous blood gas to confirm acidosis. Baseline labs. Send electrolytes, NKTL, to assess hydration, urea and creatinine for renal function and osmolality. Screen for infection only if clinically indicated. Monitoring. You must start continuous ECG monitoring to watch for T-wave changes related to potassium and perform hourly Glasgow Coma Scale, GCS, checks for neuroprotection. Slide 11. The changes in fluid therapy now, we move to the most significant update in the guidelines, fluid therapy. Historically, we restricted fluids heavily because we feared that giving too much fluid caused cerebral edema. However, in 2020, NICE reviewed the evidence, specifically the PCARN trial. This trial showed that the rate of fluid administration does not significantly impact the risk of cerebral edema. The injury is likely caused by the DTA process itself, neuroinflammation, and hypoperfusion. So, the new approach is prioritize volume restoration. We use 10 ml/kg boluses and continue fluids until the acidosis resolves. Slide 12. Fluid phase 1. Resuscitation. Let's break fluid therapy into 2 phases. Phase 1 is resuscitation. If the patient has clinical signs of dehydration, dry mucous membranes, prolonged capillary refill, you give a bolus. The bolus. 10 ml/kg of normal saline over 30 minutes. After that bolus, you must make a critical assessment. Is the patient in shock? This distinction is vital for the math we are about to do. Slide 13. Critical shock versus dehydration. Please pay close attention to this slide. This is where calculation errors happen. Scenario A. Dehydrated, but not in shock. We give the 10 ml/kg bolus over 30 minutes. Crucially, we subtract this bolus volume from the 48-hour fluid deficit calculation. Scenario B. Shock, hypotension. We give the 10 ml/kg bolus ASAP. Do not subtract this from the deficit. Treat the shock separately until circulation is restored. Always confirm shock status before doing your math. Slide 14. Fluid, phase 2, the 48-hour plan. Phase 2 is the 48-hour plan. We spread rehydration evenly over 2 days. Here is the formula. Fluid deficit, initial bolus YF, applicable G 48 hours of maintenance, divided by 48 hours. This gives you the hourly infusion rate. Let's break down the components. Slide 15. Step A. Calculating deficit. Step A. The deficit. This comes back to the severity grading we did earlier. If pH is ACHA 7.1, mild mod, assume 5% dehydration, which is 50 ml kilo. If pH is CHA 7.1, severe, assume 10% dehydration, which is 100 ml kilo. Look at the example. A 20 kg child with severe DKA, pH 7. The deficit is 20 kg multiplied by 100 ml kg. Total deficit 2 ml. Slide 16. Step B. Calculating maintenance speaker. Step B. Maintenance, doita. We use the standard holiday Sager 421 rule. For the first 10 kg, 100 ml kg day. For the second 10 kg, 50 ml kg day. For weight above 20 kg, 20 ml kg day. Let's stick with our 20 kg child. First, 10 kg, 1000 ml files. Second 10 kg, 500 ml y. Daily total HU 1500 ml. Since we are calculating a 48-hour plan, we multiply by 2. 48-hour maintenance, total TUK, 3000 NEM alta. Note, there is a weight cap by E. For patients over 75 kg, use 75 kg for the calculation. Slide 17. Step C. Final calculation example now. Step C. Let's put it all together for our 20 kg child with severe DKA who received a 200 ml bolus and was not in shock. Calculate remaining deficit. Total deficit, 2000 ml, minus initial bolus, 200 ml 18 on 1000. Calculate total fluid. Remaining deficit, 18 ml plus 48th maintenance, 3000 ml J 4000, 800 ml ball. Calculate hourly rate, 4,800 ml, divided by 48 hours, Chichu, 100 ml HR Tor. The key is to be systematic. Double check these numbers every time. Slide 18. Fluid selection. What fluid goes in the bag? NICE recommends 0.9% sodium chloride with 40 ml potassium chloride. Why 0.9% saline? It's readily available and evidence-based. You might notice hyperchloremic acidosis developing, chloride levels rise, and bicarb stays low. Do not panic. This is asymptomatic and self-limiting. Do not confuse it with worsening DKA. Slide 19. Potassium replacement regarding potassium. Standard protocol. Add 40 mol LKTL to all fluids immediately. There are only 2 exceptions. Anuria. If they haven't peed yet, hold the KCHA. Hyperkalemia. If serum Chi is Xia 5.5 ml, hold the KCHA. Critical safety note. If the patient is hypokalemic at diagnosis, you must start potassium replacement before you start insulin. Insulin drives potassium into cells, and if you start insulin on a hypokalemic patient, you risk fatal arrhythmias. Slide 20. Insulin timing. June. Speaking of insulin, let's talk about timing. Safety first. Diet. NICE advises initiating RV insulin 1 to 2 hours after starting PARV fluid therapy. Why the delay? It allows for volume expansion. It reduces the risk of cerebral edema. Early insulin is a risk factor. It reduces the risk of hypokalemia. Slide 21. Insulin dosing and administration. When you do start insulin, use a fixed-rate infusion of 0.05 to 0.1 units kJ. Use soluble insulin like actrapid or Humulin SR. Critical alert: insulin boluses are contraindicated in children. As we saw in our local audit, 12.4% of children receive them. We must eliminate this practice. If the patient is on an insulin pump, disconnect the pump, remove the cannula, and manage them strictly on the IV infusion. Slide 22. Managing glucose drop as you treat. Glucose will drop. What do you do when it falls below 14 mmol? Add glucose. Change the fluid bag to 0.9% sodium chloride with 5% dextrose. Continue insulin. Do not stop the insulin infusion. We need insulin to clear the ketones. Even if glucose is falling, keep the insulin running and adjust the dextrose to maintain blood sugar. Monitor ketones. Keep checking to ensure they are clearing. Slide 23. Hypoglycemia protocol. However, if they hit true hypoglycemia, plasma glucose at 4 mmol, stop insulin immediately. Give a dextrose bolus, 2 ml/kg of 10% dextrose before recheck every 15 minutes. Restart insulin only once glucose is above 4 mmol. Slide 24. Nursing and monitoring routine. Safe management requires strict monitoring. Hourly. Capillary glucose, vitals, fluid balance and Glasgow Coma Scale, GCS. Every 2-4 hours. Venous blood gas and blood ketones. Our target indicator for success is a ketone drop of greater than 0.5 mmol/hour. Slide 25. Cerebral edema. We monitor GCS so closely because of cerebral edema. It is rare, 0.8% locally, but it is the killer, with a mortality rate of 20-25%. It usually strikes 4 to 12 hours after treatment starts. Risk factors: younger age, new onset diabetes, severe acidosis, pH 7.1, and high bun at presentation. Slide 26. Warning signs of cerebral edema. You must recognize the warning signs early. Do not wait for Cushing's triad, bradycardia, hypertension, respiratory depression. Those are late, pre-terminal signs. Watch for headache, especially if worsening, agitation, irritability, or a recurrence of vomiting. Warning: if you suspect it clinically, treat immediately. Do not wait for a CT scan. Slide 27. Managing cerebral edema. Here is the immediate treatment protocol. Medication: give hypertonic saline, 3%, 2.5, 5 ml/kg, or mannitol, 20%, 0.5, 1 g/kg over 10-15 minutes. Fluids: restrict maintenance fluids by 50%. Positioning: elevate head to 30 degrees. Call PICU. Get senior help immediately. Again, clinical suspicion is enough to start treatment. Time is brain. Slide 28. Other complications beyond cerebral edema. Watch for hypokalemia, causing arrhythmias. Hyperchloremic acidosis, from large volumes of saline, self-limiting. Venous thromboembolism. Consider prophylaxis if they have a central line. Acute kidney injury. Monitor urine output closely. IS 29. Resolution criteria. Speaker: when can we say DKA is resolved? When all of these criteria are met. pH 7.3 bicarbonate, DO 115, mmol blood ketones. 0.6 ml clinical status. The patient is alert and tolerating oral intake. Slide 30. Transition to subcutaneous insulin. The transition from IV to subcutaneous insulin is a danger zone for rebound hyperglycemia. Follow the golden rule. Never stop IV insulin without an overlap. Give the SC rapid-acting insulin with a meal. Continue a 4E insulin for 30 minutes after the injection. Only then, stop the IV insulin. Ensure basal insulin has been given. Slide 31. Discharge and prevention. Finally, discharge is about education. We must teach parents the sick day rules. Never stop insulin, even if the child is ill and not eating much. Check ketones if glucose is high 14 mol/L. Use a blood ketone meter, not urine strips, for accuracy. Keep well hydrated. Slide 32. Summary of key changes to summarize the shift in practice from the old way to the new NICE 18 standard. Fluids. From restriction to volume resuscitation, 10 ml kg. Calculation. From subtracting all boluses to subtracting only if not in shock. Insulin. From immediate start to delayed 1-2 hours. Bolus. From insulin boluses to no insulin bolus. Monitoring. From urine ketones to blood ketones. Slide 33. Final in conclusion, our goal is safe, standardized care. We follow a 48-hour rehydration plan using 0.9% saline I. We use a fixed-rate insulin infusion with a delayed start. And we perform hourly GCS monitoring as our most effective tool against mortality. Let's work together to eliminate insulin boluses in our aids and manage fluids precisely. Slide 34. Thank you, speaker. Thank you for your attention.